Dr. Neeraj, Dr. Srishti, and Dr. Tanya from Department of Radiodiagnosis will present today's clinical grand round on role of cardiac MRI in the diagnosis of non-ischemic myocardial diseases. So in this presentation, first we'll give you the overview of cardiac MRI pertaining to the non-ischemic myocardial diseases, followed by a few representative cases. We all know that the MRI per se takes a lot of time, which is more so in cases of cardiac MRI. So the indication need to be absolutely clear. Both the clinician or the clinic referring physician and the radiologist need to be absolutely clear about what information they want from the cardiac MRI so that the study can be tailored accordingly and the desired information can be obtained in a more effective manner. It's a popular belief that cardiac MRI can only be done on 3 Tesla MRI. This is not the case. In fact, the MRI done on 1.5 T machine will produces images with less artifact. The 3T definitely offers better signal to noise ratio, higher speed, but due to its high magnetic strength, it is associated with more artifacts. It is the single modality which can provide precise assessment of ventricular function and comprehensive tissue characterization in a single examination. As it is a magnetic based study, there is no risk of ionizing radiation. The cine imaging and the late gadolinium enhancement imaging are the two main pillars of the cardiac MRI. The cine imaging, which will be done with the help of balanced SSFP sequence. It will help us in accurate calculation of ventricular volumes, mass, function, and detection of wall motion abnormality and the valvular jet. But all these information can also be obtained in a very effective manner with the help of echocardiography, which is a readily available and relatively inexpensive modality. So the main role of cardiac MRI lies in its ability to do the tissue characterization with the help of late gadolinium enhancement imaging, the black blood pool imaging, T1 and T2 sequence, and various mapping techniques such as T1 and T2. Let's see how we acquire the common MRI plane. One of the most common plane we acquire is a short axis plane. In short axis plane, the slice is cut perpendicular to the interventricular septum, and this will give rise to this image. So in short axis image, the right ventricle lies anteriorly, which is a triangular shaped structure, and the left ventricle is situated posteriorly. This is the horizontal long axis view in which you see the right ventricle is anteriorly located structure anteriorly on the right side with a relatively thin wall, and the left ventricle is located posteriorly and on the left side. Let's see how the normal images looks like on cine as well as the late gadolinium enhancement images. On cine images, the normal myocardium is uniformly dark while the blood pool is uniformly bright. The similar appearance is seen on the late gadolinium enhancement images. In this, normal myocardium is uniformly dark and the blood pool is bright. Let's see how we acquire this late gadolinium enhancement imaging. After the acquisition of cine images, we inject the gadolinium contrast agent. We wait for 6 to 8 minutes to allow the contrast to reach the myocardium, and then we run a sequence which is known as a T1 scout. This sequence is very important because it helps us in selecting the image with the myocardial nulling, and then we acquire the post contrast image. So the normal myocardium is uniformly dark, while any bright areas or any areas of enhancement along the dark myocardium suggest the abnormal pathology, which may be due to fibrosis as in cases of ischemia, which may be due to edema in cases of myocarditis or sarcoid, and it may be due to increased extracellular matrix such as in cases of amyloidosis. So let's see certain other advantages of late gadolinium enhancement imaging. It can help us to differentiate between the ischemic from the non-ischemic cardiomyopathies. In ischemic cardiomyopathies, the enhancing areas or the abnormal bright areas will confine to one vascular territory, and they always extend from the endo to epicardium because the endocardium is the most susceptible layer to the ischemia. For example, in this case, this is a case of right coronary infarct. In case you see this bright area along the inferior as well as inferior septal wall, and this is a normal myocardium. So you can see this bright area extend from the endocardium to the myocardium with sparing of the outer myocardium. These are the different vascular territories. So this is a case of RCA infarct. On the other hand, in non-ischemic cardiomyopathy, the enhancing areas will show different pattern of enhancement. Like you may in a single patient you may see a subendocardial enhancement, mid-wall enhancement, and epicardial enhancement. So they will not follow one particular distribution. In addition to that, the enhancing areas will not confine to one arterial territory. They usually or many of the time they involve multiple arterial territory, which is not seen in cases of ischemic cardiomyopathy. And they may not follow the typical endo to epicardial distribution, which is seen in cases of ischemic cardiomyopathy. It can also help in providing the important prognostic information. For example, in non-ischemic cardiomyopathy, if you see a late gadolinium enhancement, it generally suggests a poor prognosis. It can also help us in planning the appropriate therapeutic strategy. For example, if you see an area of myocardial fibrosis or the delayed enhancement involve more than 50% width of the myocardium, then those patients will not be benefited with the revascularization procedure such as stenting. It can also help us in finding or determining the arrhythmic foci, which will appear as a bright signal intensity on the dark myocardium. So these areas can be targeted with the radiofrequency ablation. So it is expected from cardiac MRI to answer these 4 questions. What is the cause of cardiomyopathy? What is the extent of ventricular systolic dysfunction? What portion of the myocardium is viable? And what is the pattern of LV thickening and hypertrophy? So as you can see, almost all 4 questions can be answered with the help of SSFP, which is a cine imaging technique, and the late gadolinium enhancement imaging. So the first is a case of sarcoidosis, in which you can see these bright areas or the abnormal enhancement is located on the epicardial or the right ventricular side of the interventricular septum and extend up to the mid wall. Some patchy areas of abnormal enhancement also seen along the inferior and the inferior lateral wall, and also some similar areas are also seen in the lateral wall. The second is a case of arrhythmia. You can see the ventricles are dilated, particularly the right ventricle and the right atrium. The third is case of ischemia, the case which I have just shown in the previous slide. And the last one is a case of hypertrophic cardiomyopathy, in which you can see there is circumferential hypertrophy of the interventricular septum as well as the lateral wall. So let's see what is the role of cardiac MRI in primary prevention of sudden cardiac death and implantable cardioverter defibrillator placement in non-ischemic cardiomyopathy. So the current classmate recommendation for primary prevention ICD placement is it can only be placed if the patient have a NYHA grade class 2 and class 3 symptoms and LV ejection fraction of less than 35% after 3 months of guideline mediated therapy. But what about the patient who have ejection fraction of more than 35%? Are they not susceptible for the sudden cardiac death or related complication? Yes, they are. Quite a few studies have shown that even the patient having a more than 35% ejection fraction, still they are susceptible for the complication. So here comes the role of cardiac MRI. If you see a presence of abnormal enhancement in the myocardium, even though the patient is not fulfilling the class 1 recommendation criteria, then those patients can also be benefited with the primary prevention ICD placement. So this is an exhaustive list of causes which can involve the heart in cases of non-ischemic myocarditis. The causes may be primary cardiomyopathy, which predominantly involves the heart. They may be genetic, like such as hypertrophic cardiomyopathy, arrhythmogenic right ventricular dysplasia. They may be acquired, such as myocarditis, and peripartum cardiomyopathies, and the mixed variety such as dilated cardiomyopathy. The heart can be involved as a part of multi-system or involvement in case of secondary cardiomyopathies, which can be infiltrative such as amyloidosis, storage disorders like hemochromatosis, toxic metabolic causes, inflammatory conditions such as sarcoidosis. For the sake of presentation, we have broadly categorized the myocardial diseases into the non-ischemic and the ischemic varieties. And in the non-ischemic variety, we have selected 4 conditions, or we are going to present a 4 conditions, which are amyloidosis, sarcoidosis, non-compaction cardiomyopathies, and arrhythmogenic right ventricular cardiomyopathy. We have chosen these 4 conditions because they have fairly characteristic MRI finding and they are not uncommon in our clinical setup. So here I would like to invite Dr. Srishti to come over and present the first 2 cases. Thank
you. Good morning, everyone. So the first case that we're going to discuss today is arrhythmogenic right ventricular cardiomyopathy. This condition is characterized by fatty or fibrofatty infiltration of the right ventricular myocytes, and as the name suggests, has always been known to involve the right ventricle. Within the right ventricle, the most common area involved has been grouped together as and termed as the triangle of dysplasia. Within the triangle of dysplasia, the most common site of involvement by this condition has been thought to be the right ventricular apex. However, studies over the past decade have shown that the most common site of involvement is actually the epicardial subtricuspid region and the basal right ventricular free wall. In fact, cadaver studies over the last decade have shown that the left ventricle is involved in up to 70% of the cases of this condition, and in fact, the left ventricular lateral wall is significantly more involved than the previously thought more commonly involved right ventricular apex. And therefore, this condition is now increasingly being termed as arrhythmogenic cardiomyopathy instead of arrhythmogenic right ventricular cardiomyopathy. Now, as far as the epidemiology of this condition is concerned, it has a genetic basis with autosomal dominant pattern of inheritance. It has been known to involve young and middle-aged group. Because of the structurally abnormal right ventricle, these patients are prone to recurrent ventricular tachycardias, often leading to syncope. And in fact, it is responsible for up to 5% of sudden cardiac deaths in young athletes. The diagnosis of ARVC is difficult because no single modality is specific enough for its diagnosis, and therefore a complex set of criteria have been brought together to form the task force criteria. It includes a number of parameters including structural, histologic, electrocardiographic, genetic, as well as arrhythmic, and each of these parameters have been divided into major and minor criteria. The diagnosis of ARVC requires the presence of 2 major, 1 major and 2 minor, or the presence of 4 minor criteria. Here we are going to discuss the role of cardiac MRI, which is in the evaluation of the structural parameters of the disease. So the major criteria described under the task force for cardiac MR is regional right ventricular akinesia, meaning no motion, dyskinesia, meaning abnormal motion, like a segment of ventricular myocardium is expanding instead of contracting in ventricular systole, and this synchronous right ventricular contraction, meaning different segments of the right ventricular myocardium are contracting at different times. Along with these qualitative parameters, few quantitative parameters and few cutoffs have also been given for the diagnosis of this condition, and these cutoffs are the right ventricular end diastolic volume per body surface area of more than 110 for males, and more than equal to 100 for females, and for ejection fraction less than equal to 40%. For the minor criteria, while the qualitative parameters are same as the major criteria, there are subtle differences in the cutoff values. Like for end diastolic volume, the cutoff is 100 to 110 for males, 90 to 100 in case of females, and the right ventricular ejection fraction is between 40 to 45%. So here is a case of a 26-year-old male patient who had presented to cardiology with palpitations and syncopal attacks for last 3 months. ECG had shown dilated right ventricular myocardium and dilated right ventricular myocardium, and cardiac MRI was suggested to rule out some infiltrative cardiomyopathy. So in this case, we can see that the right ventricle, this is the right ventricle, we can see that the right ventricle is dilated, and while the rest of the myocardium is contracting, we can see This is the right ventricular outflow tract, and in this subtricuspid region, we can see that there's a segment of the myocardium which is bulging outwards instead of contracting during systole. And therefore, this is a dyskinetic segment. Similarly, this is another patient with similar features who had presented similarly to cardiology. And this cardiac MRI again shows that while the rest of the right ventricle is contracting, we can see this subtricuspid region is actually bulging outwards with crinkling of the myocardium. These are static images from the same cine sequences where again we can see this dyskinetic segment and the dilated right ventricular myocardium, and the second patient again the dyskinetic segment. So based on the history, clinical examination, echocardiography, and the characteristic cardiac MRI findings, a diagnosis of ARVC was made. Now, there are two other features that are often seen in these patients but have not been included in the task force criteria. And these include, for example, this is a T1 sequence, and we can see that the fat on this sequence, this is the subcutaneous fat, which appears bright on these sequences. Similarly, these bright areas within the myocardium represent fat infiltration. Earlier, this was considered to be a very specific sign for diagnosis of ARVC. However, it has been found to be very non-specific and can be seen in a number of healthy subjects as well as in elderly patients. Now, another late gadolinium enhancement, which is considered to be a very strong pillar of cardiac MRI, is also seen in these patients, involving the right ventricle in up to 88% of patients and the left ventricle in up to 61% of patients. But it has not been included in the task force criteria because assessment of enhancement in the right ventricle is very difficult because of the very thin wall, and the assessment, the enhancement in the left ventricular myocardium can be seen, but it can be seen in a number of other infiltrative cardiomyopathies, and therefore differentiating it from other cardiomyopathies is very difficult, and therefore it has not been included under the task force criteria. Now, the second case that we are going to discuss is that of cardiac amyloidosis. This condition is characterized by deposition of amyloid fibrils into the myocardium, leading to increased thickness of the myocardial wall, as well as increased stiffness of the myocardial wall. Now, the increased stiffness leads to reduced diastolic filling of the heart, and therefore leading to diastolic dysfunction. And most of the patients present to the hospital in this stage of the disease. Slowly, systolic dysfunction also ensues, ultimately leading to heart failure and often sudden cardiac death. Now, echocardiography is first performed in these patients, which shows the left ventricular wall thickening. But this can be confused with a number of other conditions, like the more commonly seen hypertensive cardiomyopathy, which will also show left ventricular hypertrophy. So few other things that are more specific for cases of cardiac amyloidosis are the presence of biventricular wall thickening, that is presence of right ventricular thickening along with left ventricular wall thickening, the thickening of right atrial wall, as well as the thickening of the interatrial septum to more than 6 mm. This thickening of the interatrial septum is considered to be is quite specific for the diagnosis of cardiac amyloidosis. So this is again a cine image where this was a patient of chronic asthma on therapy who had presented with an episode of syncope, for which he was evaluated. Cardiac MRI was performed for this patient, in which in these cine sequences we can see left ventricle is diffusely hypertrophic. Along with this, we can see that the right ventricular wall is also thickened, and more specifically we can see thickening of the interatrial septum and thickening of the posterior wall of the right atrium is also noted. Based on these findings, a suspicion of cardiac amyloidosis was raised, and subsequently biopsy of abdominal fat pad was positive for amyloid, and the myeloma workup was also positive for this patient. So for another very important role of cardiac MR in tissue characterization using late gadolinium enhancement. So late gadolinium enhancement can be seen in cardiac amyloidosis patients. However, the extent of this enhancement depends upon the amyloid burden and can range from no late gadolinium enhancement to subendocardial enhancement up to transmural enhancement, that is involving the entire extent of the ventricular myocardium. But the most common pattern of enhancement is actually global subendocardial pattern. We can see in this image, this black area is the ventricular myocardium with the nulled signal, and these bright areas along the endocardial surface actually represent subendocardial enhancement. Along with this feature, a very important point to note is the blood pool, which appears black in this image. So what happens is that in normal patients, For example, this is a case of sarcoidosis, or even if we consider a normal patient, while performing a late gadolinium sequence, the blood remains bright while the myocardium remains black. But in case of cardiac amyloidosis, what happens is that because the amyloid has a very strong affinity for gadolinium, all the gadolinium is pulled out of the blood pool, and therefore the blood becomes black, and the myocardium appears enhancing depending upon the amyloid burden. And therefore the global subendocardial pattern of enhancement along with black blood pool is a very important characteristic of cardiac amyloidosis. Now, another thing that we see while performing cardiac MRI, this is a very technical parameter that gives us a hint that we might be dealing with a case of cardiac amyloidosis. So what happens is that while performing cardiac MR, first we can see in these subsequent sequences, T1 scout sequences, we can see that in normal patients, first the signal from the blood is lost before the myocardium becomes black. But in cases of amyloidosis, the myocardium becomes black before the signal from the blood is lost. And this is a technical parameter, and this gives us a hint that we might be dealing with a case of cardiac amyloidosis. There are two newer sequences that are also being used, which are T1 mapping and the measurement of the extracellular volume, which play a major role in assessment of prognosis for this disease. Because of the deposition of myeloid, the T1 values are significantly increased in patients of cardiac amyloidosis, and this increased T1 values correlate with systolic and diastolic dysfunction. This T1 mapping can also be followed up to look for any response to treatment, and more importantly, it can be performed without administration of contrast, and therefore can also be done in patients with advanced renal failure, which is often seen in patients of cardiac amyloidosis. A number of studies have given cutoff values for the native T1 and extracellular volume for determining which are indicative of poor prognosis. However, the limitation of these sequences is the lack of reproducibility for different scanners and different strengths. Now I would like to call Dr. Tanya for discussion of the next two cases.
So good morning, everyone. Now we'll begin with the next case, which is of cardiac sarcoidosis. Now, sarcoidosis is a common clinical entity, which is a multisystemic inflammatory disorder of idiopathic origin, which can potentially involve any organ system. And according to various studies, involvement of the heart has been found to occur in a range of 5 to 25% of all cases. Also, in a number of autopsy studies, isolated cardiac sarcoidosis has been found to occur in 25% of all cases of cardiac sarcoidosis. Now, in this disease, there is granulomatous infiltration of the heart, which can lead to an array of clinical manifestations, depending on the number and location of the granuloma and the extent of involvement of the heart, with the most common symptoms being with the most common clinical manifestations being conduction abnormalities and arrhythmias. With extensive involvement of the heart, congestive heart failure can also result. And in a small number of cases, sudden cardiac death can also occur in cases of cardiac sarcoidosis, which occurs most commonly because of conduction abnormalities and tachyarrhythmias. Now, cardiac MRI has a very important role to play in the diagnosis of this clinical entity, since no gold standard diagnostic test exists. Though endomyocardial biopsy coming positive is definitive for this disease, however, it has a very low sensitivity of only 30% and is rarely performed because of the high risk of complications due to its invasive nature. In accordance with this fact, the recently updated guidelines by the Japanese Ministry of Health and Welfare 2017 have downgraded endomyocardial biopsy to a minor criterion for the diagnosis of cardiac sarcoidosis and have instead upgraded cardiac MRI as one of the major criteria for the diagnosis of this condition. So coming on to the imaging manifestations of sarcoidosis on cardiac MRI, we can again segregate the imaging features into morphological and functional abnormalities and tissue characterization using late gadolinium enhancement sequence. So among morphological abnormalities, focal or global wall thickening or thinning of the myocardium can be seen depending on the stage of the disease, that is inflammatory versus fibrotic. And on CNS sequences, regional wall motion abnormalities, presence of focal aneurysms, and global hypokinesia is commonly seen. So this is the cardiac MRI which was performed in a young patient who had history of recurrent palpitations and syncopal attacks for the past 3 years and was admitted to our institute in a state of VT stroke. Echocardiography of the same patient was performed, which had diagnosed systolic dysfunction and poor ejection fraction for the patient. And these are the cine short axis views of the heart of the same patient, demonstrating diffuse circumferential wall thickening of the left ventricle. The contractility of the heart is reduced, and there is also a thin rim of pericardial effusion in this sequence. Coming on to the late gadolinium enhancement images of the same patient. These are the horizontal long axis views of the heart, and these are the short axis views of the heart of the same patient. The patchy bright areas which are seen within the myocardium are the abnormal areas, which are areas of gadolinium retention on these late gadolinium enhancement images. So in this patient, there is patchy uptake of gadolinium in the mid myocardium involving the entire interventricular septum. This abnormal enhancement is also extending along the subepicardial surface, along the free wall of the right ventricle and the free wall of the left ventricle. These are the short axis views of the same patient, again demonstrating abnormal patchy areas of enhancement along the mid wall of the interventricular septum and extension of enhancement along the subepicardial surface, along the anterolateral and the inferolateral walls of the left ventricle. So based on these findings, the possibility of cardiac sarcoidosis was considered on cardiac MRI. Further, HRCT of the patient of the chest was performed, which suggested mediastinal lymphadenopathy. At the time of presentation, serum ACE levels of the patient were raised, which subsided following IV pulse methylprednisolone treatment, and subsequently, biopsy from the mediastinal lymph nodes suggested sarcoidosis. So coming on to the pattern of enhancement in sarcoidosis. Late gadolinium enhancement confers a high amount of sensitivity and specificity for the diagnosis of this condition. However, there is no pattern which is specific for sarcoidosis. However, the most common pattern which has been documented in literature is patchy subepicardial and mid-wall late gadolinium enhancement involving the basal part of the interventricular septum. The other important areas that are involved are the free walls of the right and the left lateral ventricles. Involvement of the atria has also been documented in a small number of cases. Involvement of the pericardium can also be seen in the form of pericardial thickening and pericardial effusion. Extension of the enhancement along the RV insertion points has been considered to be quite specific for the diagnosis of sarcoidosis. Another important point to note is the sparing of the endocardium and involvement of the myocardium in a non-vascular distribution, which helps us differentiate it from ischemic cardiomyopathy. This is another case of extracardiac biopsy-proven sarcoidosis, and this is the cardiac MRI of the patient demonstrating late gadolinium enhancement. This is the horizontal long axis view of the heart, and this is the short axis view of the heart, demonstrating patchy mid-myocardial enhancement involving the interventricular septum, and this enhancement is extending along the RV insertion points of which is seen here. And this is the short axis view of the heart, again demonstrating mid-wall late gadolinium enhancement involving the interventricular septum and subepicardial enhancement along the anterolateral, the inferolateral, and the inferior wall of the left ventricle. This extension of enhancement from the septum is seen to go across to the RV insertion points, and this enhancement at the RV aspect of the septum is quite specific for sarcoidosis and has been labeled as the hook sign or the triangle sign. Now, apart from diagnostic ability, late gadolinium enhancement in sarcoidosis also has an important prognostic value. Late gadolinium enhancement has a very high negative predictive value for adverse outcomes, including arrhythmic events, such that even in the presence of known extracardiac sarcoidosis, the absence of late gadolinium enhancement, with the absence of late gadolinium enhancement, the possibility of clinically relevant sarcoid heart involvement is quite low. On the other hand, according to a certain study, involvement of more than 20% of the left ventricular mass with late gadolinium enhancement suggests increased risk of mortality, heart failure, and life-threatening arrhythmias in such patients, and poor recovery of LV function following steroid therapy. Despite these advantages, there are certain drawbacks associated with LG in sarcoidosis, with the first being its low sensitivity in very early disease. In the very early disease, in cases of early inflammatory stage, FDG PET has been found to have better sensitivity for detection of sarcoidosis. Secondly, late gadolinium enhancement sequence in sarcoidosis, and this disease per se has been known as the great masquerader and becomes a potential mimic in many cases of myocardial diseases. No specific pattern is diagnostic. However, in correct clinical setting, supplemented by imaging features from other modalities, and the most common pattern of enhancement, which is the patchy mid-myocardial and subepicardial enhancement in a non-vascular distribution, is quite specific for sarcoidosis. Thirdly, negative late gadolinium enhancement does not rule out cardiac sarcoidosis completely. So now we come on to the next myocardial disease, which is left ventricular non-compaction cardiomyopathy. Now, this is a primary genetic cardiomyopathy, which is a genetically heterogeneous disorder with variable penetrance, which manifests in the form of structural heart disease. Many patients remain asymptomatic. However, with increased burden of involvement of the heart, the patients are predisposed to cardiac failure and development of malignant arrhythmia. And also because of the hypertrabeculated structure of the heart, patients are predisposed to development of thromboembolic episodes as well. Now, compaction is a normal process which occurs during fetal life. The myocardium starts off as a spongy structure and undergoes compaction during the 5th to the 8th week of fetal life. And this process of compaction follows a specific pattern that begins from the epicardium, proceeds towards the endocardium, starts from the base and extends to the apex, and extends from the septum to the free wall of the left ventricle. And any arrest in this normal process of compaction will lead to this LV non-compaction cardiomyopathy, in which the ventricular apex is almost always involved because of this pattern of normal compaction. The other important areas involved are the apical segments of the heart and the anterolateral and inferolateral segments of the left ventricle. Now, cardiac MRI is the investigation of choice for the diagnosis of this condition, where two distinct myocardial layers can be identified, that is the compacted and the non-compacted layers. And according to Peterson's criteria, in the end diastolic phase, the ratio of the non-compacted to compacted myocardium should be greater than 2.3. The other important features that can be seen are marked trabeculations and presence of deep intertrabecular recesses. So this is the cardiac MRI which was performed in our department. The patient was a young patient who had history of syncopal attacks, and on echocardiography, poor systolic function was diagnosed and suspicion of non-compaction cardiomyopathy was raised, following which cardiac MRI was performed. And these are the short axis views of the heart, with this being the right ventricle and this being the left ventricle. There is appearance of two distinct myocardial layers, the non-compacted layer and the compacted layer of the myocardium along the free wall of the left ventricle, with a thickened non-compacted layer which definitely has a ratio of more than 2.3 times of the compacted layer. And these are the cine sequences of the same patient. And this is the short axis view of the heart, and this is the horizontal long axis view of the heart, again demonstrating thickened non-compacted layer along the anterolateral, the inferolateral, and the inferior segment of the left ventricle. The contractility of the heart is reduced. Seeing these features of thickened non-compacted layer and reduced contractility, the diagnosis of non-compaction cardiomyopathy was made. With this, I would like to hand over to Sir to carry forward the presentation.
Thanks, Dr. Tanya. So we have seen the cardiac abnormalities in some of the condition. Let's see what are the different pattern of LG enhancement in various non-ischemic cardiomyopathy. So the enhancement patterns are broadly divided into the subendocardial, mid-wall, and the epicardial enhancement. But these enhancement patterns are not exclusive. For example, you can see here, in cases of sarcoidosis and myocarditis, you may see a presence of mid-wall enhancement in the lateral wall, as well as the epicardial enhancement in the lateral as well as inferior lateral wall, and the epicardial enhancement along the RV side of interventricular septum. So the information derived from the cardiac MRI need to be read in a clinical context and in the light of various laboratory parameters. The subendocardial enhancement, the global subendocardial enhancement is said to be very specific for amyloidosis, but can also be seen in cases of systemic sclerosis. You may see a subendocardial enhancement in cases of subendocardial infarction or the ischemia, but this enhancement will confine to the one vascular territory, like in this case to the RC territory, and they extend from the endo to epicardium, like in this case of transmural infarction. The mid-wall enhancement, like in this case, at the RB hinge point. The RB hinge point is where the RB attached to the left ventricle is said to be quite specific for hypertrophic cardiomyopathy, but it's not 100% diagnostic. In fact, it is also seen in other condition with right ventricular overload. The dilated cardiomyopathy characteristically, the idiopathic dilated cardiomyopathy characteristically shows a thin enhancement in the interventricular septum, but this can also be seen in case of myocarditis. So you can see there is quite a bit overlap exists between the different conditions ranging from the amyloidosis to the ischemic. So all these information need to be read in a clinical context. So lastly, I would like to show you a chart by which how to approach a case of cardiac non-ischemic cardiomyopathy or the cardiac myopathy with the help of the cardiac MRI. The first set of images we need to look at is the lead gadolinium enhancement, and if we found that enhancement is positive, then what is the pattern of abnormalities? If it is an infarct scar, which means if it extends from the endo to epicardium, then we are dealing with a case of ischemic cardiomyopathy. If the enhancement pattern is not confined to the vascular territory and you may see a different pattern of enhancement, then we are dealing with a non-ischemic cardiomyopathy, which may be due to myocarditis, in which you see a subepicardial enhancement and the mid myocardial enhancement. Maybe a case of hypertrophic cardiomyopathy in which you see an enhancement in the interventricular septum mid wall at the RV hinge point, or it may be a case of infiltrative cardiomyopathy such as sarcoidosis and amyloidosis that we have already discussed. And if we found that there is no enhancement or the enhancement is negative, then we need to look at the cine imaging, and we found that the volume, the ventricular volumes have increased and the ejection fraction is decreased and the dilated chamber is the left ventricle. That means we are dealing with a case of dilated cardiomyopathy. And if the dilated chamber is right ventricle in case of increased volume and reduced ejection fraction, then we are dealing with a case of ARVC or arrhythmogenic right ventricular cardiomyopathy. The next thing we need to look at is the wall motion. If we found that there is a kinetic segment confined to one vascular territory, then this is a case of ischemia. The next is we need to look at morphology, and we found that trabeculation is increased and the ratio of non-compacted to compacted myocardium of more than 2.3, then we are dealing with the case of non-compaction cardiomyopathy. And if we found the typical pattern of LV hypertrophy, then we are dealing with the case of hypertrophic cardiomyopathy. So in conclusion, the cardiac MRI provides the precise assessment of ventricular function as well as tissue characterization in a single examination. The study need to be indication based, which means you need to be absolutely certain or clear that what information you want from the cardiac MRI, so the study can be planned accordingly. The cine and the lead gadolinium enhancement sequences are the main pillar of the cardiac MRI, and this lead gadolinium enhancement can help us in diagnosis, prognosis, as well as planning of appropriate therapeutic staging and various non-ischemic cardiomyopathy. So before we end our presentation, we would like to acknowledge the contribution and support of Department of Cardiology and Department of Cardiovascular and Thoracic Surgery. Thank you.